Sylvia Lowry is tucking her grandson into bed. He asks her, "Nana, why do you need a stick to walk?" Sylvia smiles. "My cane? Do you know that there is more to how a person feels than what you see?" Sylvia proceeds to tell her grandson about his uncle Bernard, who, in 1945, was first diagnosed with a demyelinating and progressive form of multiple sclerosis. Multiple sclerosis, or MS, is a neurological disease that can occur at any age. It affects nearly 2.5 million people worldwide. MS is the most widespread neurological condition causing disability among young people, which are considered to be those in their third and fourth decade of life. There are 4 types. The first is primary progressive MS, abbreviated PPMS. This causes steady progression of symptoms with few periods of remission. Men and those who acquire MS at an older age are more likely to have primary progressive MS. The second is relapsing remitting MS, or RRMS. This causes worsening of symptoms, or exacerbations, that occur with increasing frequency, along with periods of reduced symptoms or remissions. Optic neuritis is common in relapsing remitting MS. The third is secondary progressive MS, or SPMS. At first, it is considered to be clinically analogous to the relapsing remitting form of MS. However, SPMS, or secondary progressive MS, eventually progresses to the type of MS that has no remission. About 80% of the relapsing remitting MS patients develop secondary progressive MS after some time, typically within 7 to 15 years. For most patients, the transition from relapsing remitting MS to secondary progressive MS means that extended periods of remission will no longer occur, and on magnetic resonant imaging, MRI, the lesions become more confluent and extensive. The fourth is relapsing progressive MS, or RPMS, which causes accumulating damage during each exacerbation. There are also numerous variants of multiple sclerosis, such as Devick's disease, which is a combination of myelopathy and optic neuritis, and possible associations between multiple sclerosis and disorders such as trigeminal neuralgia, Leber's hereditary optic neuropathy, inflammatory bowel disease, and neurofibromatosis. There are many symptoms that any MS patient can experience. They can experience one or more of these. There are 3 general classifications: motor, sensory, cognitive, mental, or other types of symptoms. The first category is motor. Here, the patient can experience weakness. Now, that can be of a whole limb, of the entire body, of the lower limb. It varies. Tremors, ataxia, which means an uncoordinated gait, dyssynergia, which means difficulty in synergy of movements, dysarthria, which means problems with speech, and spasticity. The sensory symptoms are as follows: vision loss, diplopia, or double vision, and numerous other visual symptoms. Incontinence, which can be urinary or bowel, or a sense of urgency. Sensory disturbances, the most common being paresthesias, or numbness and tingling, dizziness, vertigo, or spinning, poor balance, and Uthoff's and Lhermitte's phenomenons. Uthoff's means that you have an increase in symptomatology after exposure to heat. It can be after a warm shower or bath, but more commonly is after being in the sun or in an office or home that is too warm. Lhermitte's, what happens with that is the patient bends their head forwards or cervical spine flexion, and they get lightning bolt symptoms down their spine, sometimes extremities. Now, the third category is what we're going to focus on more, which is the cognitive, mental, or other types of symptoms. These ones tend to be hidden or invisible, meaning that nobody can see it, but the person certainly experiences it. The first is memory loss. It usually is short-term and not long-term. Pain, emotional lability, so they can respond and be tearful more rapidly than others might in an emotional response. Depression, and here, according to the National Multiple Sclerosis Society, half of all multiple sclerosis patients will experience a major depressive episode at some point during the illness. Fatigue, which ends up being very severe, and affective changes. They just don't seem to be themselves. So again, mostly the symptoms in the last column are considered invisible or hidden disabilities, and these will be the ones that we're focusing on. In many countries, multiple sclerosis is the leading cause of non-traumatic disability in young adults. While some people with multiple sclerosis experience little disability during their lifetime, as many as 60% may be struggling to walk unaided 20 years after onset. However, the statistics are largely unavailable for the invisible or hidden symptoms. Some multiple sclerosis patients will never have problems with walking. They may have fatigue or problems thinking, cognitive problems, as their only disabilities. Sylvia said that she and Uncle Bernard felt weighed down by the diagnosis. They had no idea what was in store for his future. You see, at that time, not much was known about multiple sclerosis. Would his condition be visible? Would he have tremors, gait disturbance, or would he have problems with severe fatigue or thinking? The course of MS is ambiguous, and the ambiguous nature of the disability can lead to stigma and prejudice. You see, the reality is that people respond differently to individuals with invisible disabilities than to individuals with visual disabilities. Sylvia tells her grandson, "Do you know that I could have a disability and not have a cane or a wheelchair? Do you know that it was the same with Uncle Bernard?" Alterations in episodic memory, processing speed, verbal fluency, and difficulty with abstract concepts and complex reasoning have been reported in the MS patient. According to the National Multiple Sclerosis Society, half of all individuals living with MS will experience cognitive problems, defined as a range of brain functions, including the ability to learn and remember, focus, maintain and shift attention as needed, organize, plan, and problem solve, understand and use language, accurately perceive the environment, and perform calculations. While only a minority of individuals with MS will develop severe cognitive problems, as everyone knows, forgetting things or feeling fuzzy-headed can be distracting and embarrassing, even dangerous. The good news is that for most people with MS, certain high-level cognitive functions remain intact, including reading comprehension, long-term memory, the ability to hold a conversation, and general intellect. Other areas such as short-term memory, where did I leave my keys, attention and concentration, information processing, visual perception, and even verbal fluency, which is finding the right words, can be affected. There was an interesting study in 2009 that compared multiple sclerosis patients with disabilities that include fatigue and cognitive disabilities with other individuals with disabilities from other disorders. This other group was defined as those whose major life activities were altered or they needed adaptive equipment. Those with multiple sclerosis reported, quote, more days with poor physical and mental health limiting their activities, end quote, than those with other disabilities. The demographics for the individuals with multiple sclerosis were different than the other individuals with disabilities. The MS population was better educated, more likely to be female and non-Hispanic white, and less likely to be employed. The other individuals with disabilities were more likely to be male, have not completed high school, and were more racially and ethnically diverse. While the results of this study may be difficult to interpret due to the numerous variables, it appears as if MS patients may have poorer outcomes and less employment than other disabilities. It would be reasonable to conclude that a possible reason is prejudice, discrimination, and oppression of this disorder, particularly those with invisible disabilities of MS. There are a number of blogs, articles, and court cases to support this statement. Here is one story. 6 years ago, Sherry Connell parked in a handicapped space at a shopping center near her home in Littleton, Colorado. When she returned, a sheriff's car was blocking hers. She showed the deputy her handicap placard, her registration, her MS Center identification card, and her driver's license, and explained that she is allowed to park in handicapped spaces because she has multiple sclerosis. He put his hands on his hips, looked down at her in disbelief, and said, I think you stole this placard. I saw you walk into the store, and I'm tired of people parking in handicapped places who don't belong there. 20 minutes later, shaking and crying in frustration, Sherry demanded the deputy's name and badge number and told him that if he didn't move his car, she was driving through it. I reported him, Sherry says, and I got an apology from the sheriff's department, but I was totally humiliated. There was also a court case, which was Pushkin versus Regents of the University of Colorado, 10th Circuit Court, 1981, where Dr. Pushkin, a medical doctor with multiple sclerosis, was denied entrance into a residency program at the University of Colorado's psychiatric unit. The university, quote, justified their decision to deny him admission, stating that A, they were concerned how patients would react to Dr. Pushkin, B, they felt Dr. Pushkin had not come to terms with his disability and that this would affect his ability to treat patients, C, Dr. Pushkin would not be able to handle the stress on the job on account of his condition, and D, that Dr. Pushkin would require too much medical care to be able to satisfy the requirements of the job, end quote. The conclusion of the case was that the university could not use, quote, broad stereotypes, end quote, to evaluate abilities to or to not perform tasks required of the medical residency program. Basically, Dr. Pushkin had his civil rights violated and was oppressed from entering the medical residency program. MS patients struggle with having their episodes of extreme fatigue understood. There are no objective tests to evaluate fatigue. Fatigue in MS patients is thought to be the most difficult disability to accommodate and the most common reason why MS patients are unable to work. This disability may be felt by the person with disability, but not seen by others. This may, according to the SMART text, cause an, quote, inconsistent level of empathy, end quote, by people without disabilities. On May 8, 2013, the Seventh Circuit Court of Appeals in Chicago, Terry Basden versus Professional Transportation Incorporated, heard a case in which an MS patient was terminated due to her irregular absenteeism. The court concluded that an employer can only be liable for a failure to accommodate if the employee is a qualified individual under the ADA. Quote, employers can consider regular attendance as an essential job requirement and are not required to accommodate erratic or unreliable attendance under the ADA, end quote. This can be a challenge in the MS patient whose primary disability is fatigue, which can worsen episodically and unpredictably. The 10th Circuit Court of Appeals in Utah, Laura Sorensen versus the University of Utah Hospital, heard a case where the MS diagnosis alone and not the lack of the ability to perform essential job functions caused a demotion in the plaintiff's place of employment. The plaintiff, during her hospital stay, could not perform any major life functions. However, the disability was temporary with no residual effects, but she did not qualify under the ADA. Her medical team cleared the plaintiff to return to work without restrictions. However, because of the one episode in the hospital, the plaintiff was told by her employer that she could no longer return to her original position. Following the court's dismissal of her case, the plaintiff explained that, quote, the university took a red paintbrush and put a scarlet MS on my forehead. I was a disease from that point on. I can do that job. That's the bottom line, end quote. Individuals with hidden disabilities, such as the severe fatigue and weakness or cognitive disabilities of multiple sclerosis, intellectual disabilities, and mental illnesses, have difficulty having a collective voice in federal, state, and local infrastructure, policies, and service benefits and programs. There needs to be an increase in vertical alignment of federal, state, and local partnerships to establish funding streams and flexible design programs to deliver the appropriate services and programs. One action specific to MS would be to reach out to similarly underserved groups, such as those with intellectual disabilities and mental illnesses, to have a greater collective voice. Collaboration with veterans with disabilities who who often have the hidden disabilities of post-traumatic stress disorder, traumatic brain injury, and other cognitive and mental health disabilities, would also increase the collective voice, particularly linking local military families, who are often a close-knit group, and federal legislation and resources. Development of national campaigns to increase awareness of the often invisible disabilities of multiple sclerosis would help to address the stigma associated with these types of disabilities. MS Active Source, MS Society publications, and support groups are good sources of information for a better understanding of multiple sclerosis symptoms. Also, incorporation of specific training for educators, administrators, healthcare providers, legislators, architects, and builders in the universality or equal opportunity situation of disability would increase the competence to handle disabilities. I think that the area to markedly improve lives for people with disabilities is the education of the latter, the architects, builders, and individuals who contribute to physical infrastructure. There is an increasing desire to strengthen people with invisible disabilities, their families, and communities by broadening advocacy of people with disabilities. The definition of underserved needs to include those that have invisible disabilities so that they can be included in decisions regarding research, programs, and services. SMART states that, quote, the salience of the disability means that the disability is the most important or the only aspect of the individual, end quote. Sylvia understands that her cane makes her different than others, but it is only a single aspect to her identity. She explains this to her grandson. She also tells him that it does not limit how much she treasures time with him, nor how much she loves him.